welcome to TCTAP VALVE 2020 virtual meeting. My name is D.W. Park from Asan Medical Center. The end of last year, after report of a 5-year result of Excel trial, there have been a lot of controversy on optimal revascularization strategy for left main coronary artery disease between surgeons and interventionists. This issue sparked a massive firestorm, and the European Association for Cardiothoracic Surgery recently filled out their support from Class 1 guideline recommendation or left main PCI for low-risk patients. To hear background real story on disputed argument, we invited top experts at both ends of interventional cardiology and cardiac surgeon. This special debate session is most interesting and helpful for clinicians and the audience to understand the innermost thought and perspective of each part. I would like to introduce co-moderator in this special session, Dr. Spencer King and Dr. Domenico Pagano.
Hi, good day everybody, and welcome to one of the most exciting sessions on left main and PCI bifurcation. I am privileged to introduce the two speakers for this session. It's Dr. Park for the Asan Medical Center in Korea, and my old friend, Dr. Taggart from the University of Oxford.
The first presentation will be by Dr. S.J. Park, who's going to present the updated presentation of left main PCI versus CABG with the perspective of interventional cardiology.
Sir, it's really good to see you. Today I'm very happy to have a debate session with Dr. David Taggart. It's a great. Anyways, I will start with interventionist perspective in terms of versus CABG for the main disease. Up to this point, 2016, not many randomized studies for the main disease in compare registries and text main subgroup pre-combat Excel global study. 2016, actually we have performed the patient level meta-analysis with the syntax-based pre-combat, including 6,280 patients. If you look at the multi-vessel subset, primary endpoint DAS-MI stroke at 5 years, clearly separate. Surgery is better than the PCI. However, totally different, trend in terms of the main subset, primary endpoint, including DAS-MI stroke at 5 years, absolutely same, no difference between the PCI versus bypass surgery. That is our global multi-center registry data, 20 years temporal changes in PCI versus bypass surgery for the main disease, including the 6,000, more than that, main registries. Look at this, current practice has more than 60% of the cases would be treated by PCI with a drug-eluting stent. If you look at the short-term, 3 years outcomes, actually DAS-MI stroke, not statistical difference. However, PCI and surgery is comparable. The rate of myocardial infarction is clearly higher in a group of the PCI, stroke, no difference between the two. If you look at the subgroup analysis, the patient who had a history of heart failure, chronic kidney disease, and low ejection fraction, the patient group who are still in the bypass surgery is better than PCI. Relatively young age, less than 65, as a PCI is better. If you look at temporal changes last 20 years, we have already changed it. More than 60% of our main disease were treated by PCI with a drug-eluting stent in real-world practice. 2016, first publications from the Excel study at 3 years, actually not statistical difference, primary endpoint, death, stroke, myocardial infarctions. Same time, the Noble study, non-procedural MI, including the repeat revascularization and stroke at 3 years, clearly better outcomes in group with the surgery. And so 2018, Dr. Stewart actually had performed the patient-level meta-analysis, including the 11 randomized study, 11,000 patients, actually PCI 5,700, bypass surgery 5,700, the follow-up period 3.8, plus minus 1.4 years, around beyond 5 years follow-up data. all deaths, statistical significant better outcomes, bypass surgery compared to the PCI. If you look at the impact of main disease, multivessel disease, almost the same findings. The main actually not statistical difference between the two in terms of all-cause mortality. Multivessel, clearly bypass surgery is better. Impact of diabetics and non-diabetics, and diabetic patient surgery is better. Non-diabetic patient, actually no difference between the PCI versus bypass surgery. And so meta-analysis clearly show that PCI and bypass surgery are equivalent for the main diseases. However, bypass surgery is better for multivessel disease and diabetics at 5 years later. Why do we need long-term comparative outcomes of PCI versus bypass surgery in the main disease? Look at this, clearly contradictory result, Excel study, Noble study. There is some signals at short-term 3 and 5 years later. They catch up in terms of MACE rate, surgery versus PCI, crossover favoring bypass surgery over PCI, and we need a long-term, at least 10 years follow-up data. So from the 2018-2020 updated data being compared 10 years, Syntax 10 years, Excel 5 years, Novel 5 years, recent published pre-combat 10 years. I'd like to briefly introduce the data. Being compared 10 years, including 2,240 patients, 740, almost well-matched bypass surgery, IPTW, statistical matches. Look at this. Clearly no difference in terms of hard endpoint deaths, DS versus bypass surgery. No difference between the two. However, we have very interesting finding before and after 5 years in kind of a random analysis. After the 5 years, it's some crossover. Surgery is better. Outcomes in terms of and compared to the PCI, almost the same findings, SQMI stroke before and after 5 years. After the 5 years, it's clearly, a statistically significant better outcomes in terms of bypass surgery. TVR is clear, it's always higher, could be the PCI rather than bypass surgery. And so DS, 10 years, being compared 10 years, DS was significantly associated with a high risk of death and serious composite outcomes compared to surgery at 10 years after 5 years, kind of a late period, treatment benefit. Bypass surgery has diverged over the time during the continued follow-up data. Syntax 10 years, 2019, randomized 900, bypass surgery PCI with the Texas for 3 vessel or a main disease at 10 years follow-up data. Almost same, separate with a 3 vessel, the main disease subset, clearly different. Bypass surgery better for multi-vessel, 3 vessel disease subset. However, the main disease, actually no difference in terms of mortality concern. Impact of diabetes, actually not statistical difference. Versus surgery, non-diabetics, no significant. If you look at overall, not too much different. Separate with the random analysis is before and after, so 5 years data, actually no difference in terms of all-cause mortality. 10 years follow-up in Texas study. At 10 years, no significant difference exists between the PCI using Texas and bypass surgery among patients with a main disease. Recent published Excel 5 years, and you clearly know that 950, Science, everolimus, Livingston, bypass surgery random, and annually follow-up through 5 years. This is 2016 first published data at 3 years. All-cause death, stroke, MI, absolutely no difference between the two. At 5 years data, statistical no difference. However, there were clear, crossover in terms of bypass surgery. We trend to the, better rather than the surgery. The random analysis from 1 year, 1 month, 1 year. Look at this, some statistical difference in terms of clearly better in bypass surgery, 9.7%, 15% in PCI, all-cause death, stroke, or myocardial infarction. And you know that all-cause deaths actually a little bit higher xenogroup there. There's 13% and 9.9%. And however, non-procedural myocardial infarction is clearly higher with the PCI. And adjusted deaths concern definite cardiovascular, actually no difference, and definite non-cardiovascular symptom trend in terms of higher rate of PCI, non-cardiac causes, malignancies, and infections. In actual trial, treatment of patient with the main coronary artery disease individually assessed the low intermediate syntax score with everolimus eluding stent resulting in a similar rate of clinically meaningful composite outcome test stroke or MI at 5 years. The early benefit of PCI due to the reduced periprocedural risk was attenuated by the greater number of events occurring during the follow-up with bypass surgery, such that at 5 years, the cumulative mean time free from adverse event was similar with the post-treatment. Over 5 years, 2020, they include 600 and 5 years data. Clearly, primary endpoint, non-procedural myocardial infarction, repeated revascularization, MI, stroke, clearly better outcomes in a group with the surgery. However, if you look at the individual secondary endpoint, all deaths, absolutely no difference between the 5 years data, strong, no difference. Only difference is non-periprocedural myocardial infarction separate significantly, repeated revascularization higher in a group with the PCI rather than the surgery. And so, over 5 years, revascularization of for the main coronary artery disease, PCI was associated with inferior clinical outcomes at 5 years compared with a bypass surgery. Mortality was similar after the two procedures, but patients treated with the PCI had a higher rate of non-procedural myocardial infarction and repeat revascularization. Recent published randomized studies, pre-complete 10 years, and 300 bypass surgery, 300 with a Cypher first generation regulating stent for the main coronary artery disease at 10 years follow-up, 96% we had performed. Primary endpoint deaths, MI, stroke, or ischemic-driven TBR, actually not statistical difference. There are some trend, a little bit better outcomes bypass surgery. However, individual secondary endpoint, any cause, absolutely same between the two 10 years follow-up data, composite deaths, MI, stroke, no difference between the two. Ischemic-driven target vessel revascularization clearly higher, group with the PCI rather than bypass surgery. Key subgroup analysis, and in terms of primary endpoint, not significant difference between the two. However, the patient group who had a main with a 3 vascular disease, maybe surgery is better than the PCI. So, summary, pre-complete 10 years. This trial for the main disease randomized PCI bypass surgery did not demonstrate significant difference in incidence of one major adverse cardiac or cerebrovascular event. Surgery would be better in the main with the cerebral disease. So I draft a summary on the PCI bypass surgeries, including the long-term data. Based on the current updated long-term data, PCI with the stent had similar clinical outcomes in terms of all deaths and the stroke for the treatment of the coronary artery disease. PCI group had higher rate of non-procedural myocardial infarction and repeated revascularizations compared to the bypass surgery, which maybe is related with incomplete treated combined cerebral disease. 2018 ESS guideline for main PCI actually to get this low and intermediate syntax TCI actually a good candidate for PCI is big changes, and more than 60% of the main disease could be good candidate for PCI with a regulating stent. Right, as a guideline concern and as some data, high syntax score combined cerebral disease is really matters in our current practice. So that is my first question: why surgery is still better for both patient group? High syntax score and cerebral disease. Look at this. This is 2015 Bangalore publication in New England Journal of Medicine, New York State registry data. Propensity match compared to PCI with the giants and bypass surgery. big number, propensity metric. Look at this, hard endpoint has no difference at all. Myocardial infarction statistically higher in group with the PCI, stroke higher, surgery, repeat revascularization higher, with PCI. That is clear, the characteristics of a PCI with reducing extended bypass surgery. What about the issue of complete versus incomplete revascularization? In the Bangalore data, New York registry, look at this, incomplete revascularization, the myocardial infarction is statistically higher, 1.98%, 2%, and repeat revascularization higher, so it's higher in surgery group. However, look at that, complete revascularization, the frequency of myocardial infarction, rate of myocardial infarction is clearly same, not statistical difference in terms of PCI versus surgery. Repeat revascularization, the frequency is absolutely reduced from the 8 to 5 something. It's actually same manner. So we analyze our best studies, Giants randomized study for multivessel PCI versus surgery. Look at this. Incomplete revascularization, myocardial infarction is 7.4%, very high, rather than the bypass 31.6%. All MACE rate is clearly higher. Not statistically, look at this, complete revascularization, rate of infarctions, new myocardial infarction is 2.3%, not statistical difference between the PCI versus surgery. That means actually complete revascularization is another registries, patient level meta-analysis and the syntax best pre-combat. Look at this, any cause deaths, all deaths, deaths MI show exactly same with the complete, treated with the PCI and bypass surgery for multivessel. They did exactly the same finding. And we learned from this data, complete revascularization of a multivessel disease had a comparable clinical outcomes with the conventional bypass surgery from the registry data, from the syntax, patient level meta-analysis. And so we learned complete revascularization is an important practical issue for better clinical outcomes. So I would have to summary, all right, interventionist perspective, 2020, main only and the main with a 1 or 2 vessel disease, PCI is a good alternative to surgery. Absolute, no doubt about this one. Main with a combined 3 vessel disease, if we consider the concept of complete revascularization with the functions, with the FFR guided, something like that, as for combined 3 vessel disease subset, high syntax score, for those patient group, PCI would also be a good alternative to surgeries in 2025. All right. So I would say, I think a main disease, not surgical disease anymore. Thank you.
Yeah, so a very complete overview and presented a great deal of evidence to support your position. The next presentation from the surgical perspective by David Taggart, who, David, you probably have some of the same information and maybe a little different conclusion. So take it away.
Great, thank you. Well, let me first start by thanking Dr. S.J. Park and Dr. Duk-Woo Park and TCTAP for the opportunity to take part today. And it's great to see my old friends, Dr. Spencer King in Colombo, and my good surgical friends, Mario Gaudino and Domenico Pagano. I'm going to talk about left main from the surgical perspective today, and I'm going to largely focus on the Excel trial, simply because it is the largest and most definitive trial that really should guide our practice. So my only relevant conflicts of interest are I'm a cardiac surgeon and I was chairman of the surgical committee of the Excel trial, but withdrew from the final New England Journal publication in 2019. I think as illustrated by Dr. Park's talk, there are 4 key rules when we're ever looking at data between PCI and CABG. The first is to ask who are the trial patients, because they're often not actually typical of real clinical practice. Secondly, duration of follow-up must, if it's going to have any clinical value whatsoever, be at least 5 years, and ideally for 10 years, as we've seen in main compare and pre-combat. It's always important to note that the use of guideline-directed medical therapy is usually substantially inferior in CABG patients. And I would advise everyone looking at data and results in publications or presentations to actually first look at the data before reading the text, because often the text is contradictory to what the actual data shows. So as Dr. Park showed us, for multivessel disease without left main, CABG is a clear winner for all patients, any level of syntax score, and especially in those with diabetes. But isolated left main disease is actually really very uncommon. It probably only accounts for fewer than 5% of patients in our clinical practice, and up to 90% of patients with left main still have multivessel disease. So in 2008, we published this review article when we pointed out that up to, as I've said, 90% of patients with left main have multivessel disease, and up to 90% of left mains are distal or bifurcation lesions that are at high risk of restenosis. And therefore, we thought that the best evidence at that time still favoured coronary bypass grafting as the gold standard. Now, I would like to make at this point an acknowledgement of the extraordinary contributions of Dr. Park and his colleagues to left main disease. In 2008, they published the 3-year outcomes of the main compare registry of almost 2,500 patients. And then they conducted the first significantly large randomized trial for left main, pre-combat, and followed those patients from 2 to 5 and 10 years. Now, this is a study from the syntax trial looking at what happened in 705 patients with left main. And what it showed was there seemed to be a clear discrepancy in outcomes between PCI and CABG when patients' syntax scores went above 32. And this is what underpinned the enrollment criteria for Excel. And the 5-year outcomes of Excel were published in the New England Journal of 2019. Just to remind you, this was patients with selected left main disease and syntax scores below 33. It included 1,905 patients, but the trial was actually stopped early because the original plan had been to enroll 2,600 patients. And it's important to note these were relatively young patients, mean age 66 years, with a life expectancy of somewhere around 15 to 20 years. And the primary outcome was a composite of death, MI and stroke, but not including repeat revascularization. So why did Excel cause so much controversy? The 3 major societies for cardiothoracic surgery, one in Europe, 2 in the United States, demanded independent reanalysis of the results. Both CRF, who actually conducted the trial, and the New England Journal of Medicine announced respective investigations into both the conduct and reporting of Excel, although both investigations remain unreported to date. And the BBC flagship Newsnight programme produced 2 reports indicating the failure of Excel to report myocardial infarction data and the implications of that for the trial overall, and also the hidden concerns of the Data Safety Monitoring Board. So what are the 4 major concerns in Excel? Well, the first was the changed statistical analysis from non-inferiority at 3 years to superiority at 5 years. The second concern is interpretation of the mortality data. The third concern is the persistent failure to publish protocol-specified myocardial infarction data. And fourthly, the failure of the investigators to be prepared to share trial data. So what are the definite facts? Excel is the largest and most definitive trial of PCI versus CABG in left main disease. And the principal investigators, participants, and patients all deserve enormous credit for having participated in this trial. As I said, my conflict was I was the chairman of the surgical committee during its design and recruitment phase. The unit I work in Oxford was the 2nd largest recruiter of Excel patients worldwide. So I think that's an enormous testament to the cardiologists and surgeons in Oxford in determining to see the success of this trial. But as I pointed out, I withdrew my authorship from the final manuscript over interpretation of the data. Now, I would like to state again for the record, there was no attempt in the Excel trial to manipulate or distort the data that was actually presented. However, I believe there was a failure to present protocol-specified data that was vitally important to the true interpretation of the Excel trial. So if we first take the consideration of concern with statistical analysis, or what I've called statistical trickery, the primary outcome at 3 years was non-inferiority with an upper margin of 4.2%. At 5 years, without any discussion or explanation, the primary outcome was changed to superiority. And you can see with the 95% confidence intervals, this extended to 6.5% and therefore crossed the non-inferiority boundary. So in fact, we should have rejected that PCI was equivalent to CABG at 5 years. And it really begs the questions, were the statisticians and the New England Journal asleep, allowing this to happen? The second issue, and the main concern to me, was the mortality data at 5 years. Bearing in mind that these were relatively young patients with a mean age of 66 years and low or intermediate severity disease, there was an increase by 38% in the risk of death at 5 years. And if you look at the survival curves, you can see that they are rapidly accelerating in divergence. There was no difference in stroke. The data from myocardial infarction crossed at 3 years, and I'll come back to that. And then there was a very significant difference in the need for ischemia-driven revascularization in favor of CABG. But this data was interpreted in patients with left main coronary artery disease of low or intermediate anatomical complexity. There was no significant difference between PCI and CABG with respect to the rate of the composite outcome of death, stroke, or MI at 5 years. Now, while that may be technically true, I don't think it really was a fair presentation of what had happened in the Excel trial. And if you look at primary and secondary outcomes, we can see from 0 to 30 days, no difference, a 1% death rate in both groups, but CABG was penalized by having a much higher procedural incidence of myocardial infarction using a new, previously undefined biochemical definition. At 30 days to 1 year, there was no difference in death stroke MI, but PCI had higher repeat revascularization. And from 1 to 5 years, PCI showed a large increase in death, myocardial infarction, and repeat revascularization, but no difference in stroke. And this was still interpreted as there was no difference between PCI and CABG. Now, there have been the concerns about failure to publish myocardial infarction data has been repeatedly raised, and I don't have time to go through all of the comments, but I would point out the Excel protocol specified repeatedly that it would not only report a new biochemical definition of procedural IMI, the so-called SKY definition introduced by Dr. Stone, but we would also publish the standard definition of UDMI, and that was vital safety check to compare these two definitions, both within the Excel trial and to allow us to compare to other studies. But despite assurances that UDMI would be published, only the new definition was used, and that drove the composite endpoint, which was far higher in the CABG group. Interestingly, the UDMI data was leaked to the BBC, who presented 2 programs on it, and they reported that that data showed a far higher rate of MI in the PCI group. Why is this important? Well, this is a paper published by a number of us in December 2018, when we looked at the incidence of PCI and CABG according to the definition. And what you can see is that if you get rid of the universal definition of MI, then it appears to increase the risk of CABG procedural MI by a factor of almost 5. And that's what drove the primary endpoint that claimed no difference between PCI and CABG. And this in itself is interesting because this is from a study by Dr. Stone and Dr. Pocock, the statisticians of Excel, who reported in 2015 in the design of trials, it was very important to be careful in selecting composite endpoints. And they stated specifically, for instance, the most frequent and often least clinically relevant component tends to be the driver of event rates. For example, enzymatic myocardial infarctions. And that is precisely, despite their caution, what then happened in the Excel trial. And equally so, Dr. Stone changed his view on this when he was interpreting the ischemia trial, when he stated non-procedural MIs are more strongly related to CV death than procedural MIs. But again, this is not what happened in interpretation of the Excel trial. So what does happen if you exclude periprocedural MI from Excel? Well, it's shown in this slide by my good colleague Mario Gaudino from Cornell. And what it shows is that if you exclude periprocedural MI, then CABG is not only a clear winner for the composite endpoint of death, stroke, and non-procedural MI, but for the individual components of death and non-procedural, in other words, real myocardial infarctions, and indeed of the overall instance of repeat revascularization. The final concern from the Excel trial, I think, was this warning in the New England Journal that the investigators would not be prepared to share their data. And this begs the question, why would that be? Because it's conventional practice to share data if there's a legitimate request. And it is also puzzling that several of the Excel authors have themselves published numerous meta-analyses with data used from other studies. Dr. Park mentioned the Noble trial, so I'll just point out two differences between Noble and Excel. Although in both trials the age of the patients were the same, the mean syntax score was lower in Noble at 22 versus 26 in Excel, and in Noble only 15% of patients had diabetes versus 30% in Excel. And Dr. Park showed this data. There was no difference in all-cause mortality in the Noble trial at 5 years, but there was a highly significant reduction in procedural myocardial infarction and in repeat revascularization, both also shown in the Excel trial. The Noble investigators concluded that they reached the predefined number of endpoints. PCI remained inferior to CABG at 5 years in terms of MACE. CABG was superior to PCI, also in the group with the lowest syntax scores, less than 23. All-cause mortality was similar for PCI and CABG, and PCI resulted in higher rates of non-procedural myocardial infarction and repeat revascularization. So where has Excel left us in the continuing debate? And the answer to this is you can find any data you want to use to either support or refute the Excel trial. The first paper I show is a mortality after drug-eluting stents versus CABG for left main, a meta-analysis of randomized controlled trials. This is written by interventional cardiologists. They use the Excel plus. The magic of the meta-analysis is they then dilute the findings of the Excel trial, despite it being the largest and most definitive trial, with older, smaller, weaker studies until any mortality benefit of CABG appears to disappear. This was published in the European Heart Journal, and it's interesting, it was submitted on the 2nd of February 2020, revised on the 10th of February, and accepted on the 13th of February, and that must be pretty much a record speed for acceptance of a paper. If you look at this more thoughtful and scientifically robust analysis, a Bayesian interpretation of the Excel trial and other randomized clinical trials of left main coronary artery disease, published in JAMA Internal Medicine about a month ago by Dr. Brophy, a non-interventional cardiologist, he concluded Bayesian analysis assisted in randomized trial data interpretation and specifically suggested, whether based on Excel results alone or on the totality of available evidence, that PCI was associated with inferior long-term results for all events, including mortality, compared with CABG for patients with left main coronary artery disease. So to summarize and conclude, my take on this today is that for multivessel disease in patients who do not have left main, CABG is a clear winner for every category of multivessel disease, and especially in those with diabetes. For left main disease, CABG is a clear winner for those with more severe disease, defined as syntax scores above 32. But the two largest and most definitive trials of left main disease in patients with low and intermediate severity disease, in other words, syntax scores below 33, show CABG to be superior to PCI, including mortality in the Excel trial, and non-procedural myocardial infarction and repeat revascularization in both the Excel and Noble trial. So my personal view is that the current data suggests there should be a much more cautious approach to the use of stents in patients with low, intermediate severity left main disease, and particularly in younger patients with a long life expectancy. On that point, I'm going to conclude my talk. I'd like to thank Dr. Duk-Woo Park and SJ as ever for the opportunity to take part, and I'd like to thank TCT for the privilege of the floor for this debate. Thank you very much.
Nice presentations. Maybe, I don't know what Dr. King thinks, maybe we could ask Dr. Colombo to start the discussion, given that he has a tight schedule.
Thank you very much, and congratulations to both presenters. I think both views and both presentations have a lot of similarities, and I tend to agree with many aspects of Dr. Taggart's presentation. Nevertheless, and I hate to say, but we should look at some subgroups, and I don't like to clump multivessel all together and to clump left main together. In general, I would say that multivessel in a young patient with a good surgical team is a very appropriate choice. On the other hand, some more discrete or diffuse, so two stream, more discrete or very diffuse multivessel in an elderly patient, maybe PCI is better. So I think we always have to extract from these trials some general messages, but then become practitioner and apply to the patient in front of us the data. So this is my approach, and the approach that I like to share with my patient and to the young doctors, even diabetic. When I see a patient with a 78 and is diabetic, I wish to become diabetic at 78 or 81. The story is totally different if the patient is 55.
Yeah.
So let's not be dogmatic and call multivessel. We have the Sinta score, we have the age, we have the extent of the disease, we have the presence of total occlusion, etc., etc. So I like to be more punctual and more specific to the patient in front of us. Nevertheless,
Dr. Colombo,
yes.
Listen, if I could just make a comment to support what you're saying. I think you make this very important point. A young fit patient is very different from an elderly frail patient. So I couldn't agree more with you. But I think the other reason, or the other thing of note, is your colleague, Dr. Aleid Kiefel. She published a lovely paper back in Circulation a decade ago showing that for the patients you treated with stents who had true ostial or mid-shaft lesions with PCI, they did fantastically.
Yes, if you can treat the lesion with a short stent, don't forget that the stents were built short. The idea to make stent longer 38 millimeter, it's a funny idea.
You know, I think, as usual, Antonio's providing a lot of wisdom here. Clearly, the investigators, the presenters, of course, and the investigators are to be congratulated because we have this now a 10-year follow-up on some of these patients, which is something we didn't have at all before. But within that, we have so many different patients, as Antonio has pointed out. And as David has pointed out, and it's bothered me the most, is the endpoints, the composite endpoints. I'm a personally an enemy of composite endpoints. I think I like to keep track of all those endpoints, but when we add them all together, we get very confused. And I know that, David, you've made the case that all-cause mortality maybe is a better endpoint. But there are other things that people are interested in as they consider whether to have PCI or surgery. My question, and I'd like the panel to weigh in on this, can we, in devising future trials or in analyzing what we have, can we find the patients who should not be offered PCI? In other words, as in my experience of looking at what people are doing, the patient is in the hands of the interventional cardiologist, usually in the beginning, or some cardiologist who does cath, and they must make a decision. Am I going to go ahead and have this patient undergo PCI, or is this beyond what we should do, and should it go on to surgery? So I'm grappling with the concept of can we define the patients who should not be considered for PCI? Any of the panel want to weigh in on that?
Hi, Spencer, it's Alan Young. I think certainly, in the US, we pretty much, we use the word heart team quite a bit, but I don't think necessarily you always have to get, a group of cardiac surgeons and a group of interventional cardiologists together to decide on one patient. But certainly, I think anybody with left main disease should have a surgical consult, at least have a look and see whether that indeed has a balanced view. Because, it's easy for us to be in the cath lab in the moment of the discovery of the disease to try to fix it. But I think always it's good to step back and have another opinion and clearly to start that conversation. I think that's very important. And I think as Antonio and Spencer has pointed out, that we tend to do clinical trial, lump everything together because we need the power to show something. And then once you lump a lot of stuff together, you get rid of a lot of the details of the patient and try to have one conclusion for all. And that's impossible for left main disease, which is a very heterogeneous, combine different things together and calling it left main. So I think it's very important to unlump the patient, meaning when you see a patient to really look at the factors. And I think to me, the calcification of the left main involving both the proximal LAD and circumflex could be a very challenging situation for long-term good outcome. And for short-term, clearly we can fix it. But in the long term, I think those patients are set up for big trouble, as well as patients who have diabetes, which obviously have significant progression in disease. So I think, Spencer, you're right that there are patients that we shouldn't do. Technically we could do everyone. There's no question. It's just that the second question, the most important question, not the second, the most important question is that should we do it? And I think that's we need our surgical colleague to give us a balanced view and decide together. Just even just two people can decide on that. It doesn't have to be a hard team, which is a big word and a lot of lumped together stuff, as well as a lot of sort of I would say bureaucracy, if you may. So I would suggest that certainly always a surgeon, your trusted surgeon, your best high risk revascularization surgeon, because not all surgeons do a lot of high risk revascularization as well. Elderly, renal failure patients. So I think select your colleague that has the best, sort of hands on those patients or experience in those patients. I think that would be a good way to proceed.
If I can add one short comment. If I have in front of me a 55-year-old gentleman who has a distal left main lesion that can be treated with one single stent, 4 millimeter, and a focal lesion in the right coronary artery, we can be treated with one single short stent, and another lesion in a big OM, which can be treated with another short stent, basically 3 stents. I am not making a mistake to offer PCI, but I'm also not making a mistake to offer CABG. If I offer PCI to this patient, I have to tell him that the risk of revascularization is higher, definitely, than bypass. And the risk of death and MI are most probably similar, in my view. And then I let the patient make a decision. But this is a very specific subset. It's a 55 with very discrete lesion in a big vessel treated with short stent.
I've shown several slides in the later part of my talk in terms of issue of complete and incomplete revascularization concern. Actually, if you look at any randomized studies, even Excel study, novel study, even syntax study, pretty complete, any randomized studies actually have not, idea about the complete versus incomplete concern. So if you look at I've suggested the Bangalore data, New York data clearly demonstrate the complete revascularization reduced in non-peripheral cerebral infarction, spontaneous MI, and unplanned revascularization reduced, absolutely, right? So personally, I think it's a high syntax score. Look at this. Even high syntax score, cerebral vessel disease, if you look at the function concept FFR, only 14% of cases is cerebral vessel disease. What I would like to talk, actually, we don't have, all right, the current study is a higher frequency of MI and new region revascular, unplanned revascularization. Those kind of a shock endpoint may translate into the hard endpoint death, something like that one, right? So the reason why, multi-vessel disease, absolutely bypass surgery would be better than PCI. The reason why we have no concern in terms of idea of complete vascularization. So personally, I think even in the three vessel, combine the main disease, isolate the main disease, I don't doubt about the PCI clearly good for a single stent and even in the two stent. However, in case of a high syntax score, we got some function concept FFR. Really, the three vessel disease is 14%, very small percent, and we're gonna fix up bad ones. And in the later, so we have to consider what the PT1 is PCI feasible lesion concept. We got some data. In the big vessel, more than 2.5, lesion length less than 50, 48. It's okay, 38, it's okay. And we can fix up in terms of complete revascularization, may have better outcomes. And so, personally, I think that we need another, if possible, randomized study is basically PCI with a functional concept and complete revascularization and bypass surgery. That is my, real concern. Based on the current data, we don't talk much about it.
So that's an interesting point, Dr. Park. In fact, I think this is an interesting discussion. For the sake of having as many points as possible, maybe I can ask for brief questions and briefer answers to get more points in. I'm going to ask Dr. Gaudino something. Before I do that, one of the concerns I have is a great question to see, to have a practical view of the real world medicine. Nevertheless, we do have some data, and it's how we interpret this data that is important. And there are some concerns. For instance, I see people showing always, and Dr. Park was one, showing the 10-year syntax outcomes. But in the same paper, you also have the 12-year outcomes, which show a particular, a different picture with the coronary artery bypass grafting being better. I worry about the interpretation of the head meta-analysis, which was an extremely good contribution to the knowledge. And of course, when they compared the left main was not a subgroup. If it wasn't a subgroup, there was, you can't say there was no difference. And in fact, it couldn't have been a subgroup because even the authors admitted there is a huge overlap between the patients with left main and the patient with multivessel disease. So yes, we have to interpret the data we have properly and honestly in order for us then to start from a pragmatic view. And on this point, I'd just like to invite Professor Gaudino into the discussion.
Well, thank you, Domenico, and thanks for the privilege of being with such a fantastic panel. I think it's reassuring for someone like me to see that in the end, PCI and surgeon agree on the fact that we should individualize the treatment to the patient. And there is no clear-cut boundary or golden rule. Everybody should not get CABG and everybody should not get PCI. It's an individualized decision, and I share Professor Colombo approach to that. As a surgeon, I think something that is also very relevant is the technical aspect of the operation. We have discussed for the PCI, the PCI issue with the CTO or complex lesion. We as a surgeon also have technical consideration that need to be made. Sometimes the quality of the conduits is less than ideal. So you know from the beginning, if you cannot use arterial conduits, the guy has saphenous vein with clear varicosity, you know you are not going to do a great operation. So this is something that also need to be considered, like on the PCI guy, on the PCI side, the extent of the disease and the amount of interventional work that will be required in order to fix the lesion. So it is an individualized approach to the lesion. And I think, trials give you the treatment effect in the average patients. The reality is that the average patient does not exist. We have different patients that are very often at the spectrum of the disease in front of us, and then we have to tailor our decision to the individual patient characteristic. There is no doubt in my mind that the PCI is associated with a smoother postoperative course, but the long-term result is better for CABG. So depending where do your patient fit in that spectrum, you have to make a decision with your colleague in the heart team, which revascularization strategy is better. And now, I mean, I don't want to take too much time, but I would have a question for everybody. I think one of the big concern that I have in this particular moment is that because of the controversy on the Excel trial that David very clearly summarized, the heart team concept and the collaboration between the two fields that has been really probably the most important achievement that we have made after the SynTAC trial now is kind of jeopardized. It is a very, the Excel controversy was clearly a major dividing factor within the cardiovascular community. The European Association of Cardiothoracic Surgery withdrew from guideline. And even though I don't think that guideline should guide our practice, I think they should give an indication to our practice, but then in the end it's the individual physician decision. However, guidelines are extremely important, and not actually having a guideline at the moment on the left main, I think is very disorienting. So, well, Domenico, you are probably in the position of commenting more than anyone else on that. But in general, how do the group feel about the heart team approach after the Excel trial? Thank you.
Okay, so perhaps I just take that question straight on because it clarifies some points. Yes, and then I'll pass it on to you, Dr. Park. So the question is about the withdrawal from the guidelines. Well, it was a very difficult choice. If you look in 2011, the Institute of Medicine published a guide how to make trustworthy guidelines. And it's all about trust. And the trust comes from the process in which the guidelines are made, the management of the conflicts of interest, the number of professional issues, and the way the data is interpreted. When the BBC made the first program, as the BBC would do, would send a right to reply with allegations. And those right to reply was received from ESCTS and ESC. And of course, I was on the phone straight on to the president of the ESC to try and work collaboratively on this. We reached two different decisions. The ESCTS did not feel for a number of professional and scientific issues that have been raised, that those guidelines were trustworthy anymore. And therefore, they needed to be reviewed with urgency. From this to try and destroy the heart team, it's a complete misinterpretation of their act. Their act is a positive act. Where there is a doubt, you sit around the table again and look at it. And all of this from the SCTS was played in the public domain and transparency, and the documentation is available till today to everybody. We believe strongly in the concept of the heart team. This should not be used as an opportunity to break the heart team. It should be used as an opportunity for the heart team to work closer for the benefits of the patients. So I hope that clarifies the first point, and obviously I'm available to answer any other questions. But Dr. Park wanted to say something. Dr. Park.
Okay, so I have commented, some after report of a 5-year outcome of Excel trial, a lot of debate is still ongoing, and it definitely has ignited the firestorm of a controversy. I think in this context, this professional interactive discussion very, very important, great help to clinician and audience. So I think, some big controversy of the 5-year report Excel trial. I have 2 points. One is all-cause mortality issue. One is the MI definition issue. So, our team involved more than 15 years left main trial, from the main compare trial, pre-compare trial. Recently, we complete the 10-year follow-up report. So looking at the all-cause mortality, if non-cardiovascular death was unexpectedly higher in specific group, I think it could penalize the specific group. By contrast, MI definition from the last decades, there have been substantial change of MI definition, universal definition 2 and 3 and 4, and SKY definition. If investigator select a specific definition of MI, definitely it could penalize the specific group. So in my thought, so for taking care of a patient, for selection optimal choice of revascularization, we definitely emphasize heart team discussion. In this concept, I think for balanced interpretation of a trial result, I think heart team discussion for optimal interpretation should be mandatory to reduce interpretation bias, such as spin. So I think, I don't know what which method would be best method, like some consensus documents, some collaboration work between interventional cardiologist or cardiac surgeon. But I think in the future, we require a further step to collaborate each other for well-interpreted of a clinical trial.
Thank you very much. I know we're running out of time, but I think I should make this observation. Many years ago, the default was that it's left main automatic surgery. So that was easy because it was contraindicated. Now we go to the opposite end of the spectrum, where we have patients who weren't so much in these trials, but they're complex patients. They have heart failure. They have other conditions. And I find it now that many times the surgeon says, okay, left main complex, high risk, boom, send it to PCI. We don't want to touch. So it should go to the interventional cardiologist. So I think these are difficult questions, and it makes me wonder, because we used to send patients who are very difficult for surgery, and the surgeon would never turn them down if they were at very, very high risk of dying of their disease. But now the surgeon has an out. The surgeon can say, oh, this is too high risk. Let's have you take a shot at doing PCI. David, what do you think of that? Do you turn anybody down?
Absolutely, yes. I have never. So first, let me just say very quickly again, in Oxford, we still have a superb heart team where our cardiologists and surgeons do discuss all patients. So it hasn't impacted on us negatively. But I know there's many parts of the world where patients don't get discussed by a heart team, that the cardiologist has no check or balance, whereas the surgeon is very rarely ever in that position. So my view is, are there some patients who should definitely be done by PCI? Clearly, yes. And not just all the old, elderly, frail, sick patients, but as I alluded to earlier, I think younger patients with true osteo in mid-shaft left main without additional significant proximal coronary disease. Even young patients, Dr. Kefo and Colombo showed that they did very, very well with stents. So I think it's the heart team. The real advantage of the heart team is it allows you to individualize that decision for the individual patient. I think if you're in practice where you don't participate in a heart team, then it might be more difficult to get these decisions correct.
Dr. King, I just perhaps I just come in very briefly. Yours is a nice and provocative question, but I think that what this demonstrates is really that the approach of the heart team has improved at least the early outcomes from intervention in patients. Let's not forget, it's not just the anatomical lesion, of course, and it's the rest of the patient and the comorbidity and the life expectancy and so on. So in a functional heart team, I do expect that patients that are lower risk of surgery are done by surgeons and patients at high risk are done by PCI. That has contributed in a parallel way in reducing the mortality of the patients. Let's not forget the coronary artery bypass grafting mortality now is less than 1% in all the databases in the world for elective patients, and between 1.5 and 2% for emergency and urgent patients. That doesn't mean the surgeons are getting better because the surgeons are selected well. It means that the patient choice is better as well, and also means that the outcomes for the patients is better. So I think the heart team, it's really the answer to your question, which I think it's where we're alluding to. I don't know what we're doing. Are we doing for time? Maybe somebody's looking at the time at the moment. Do we have time for one more question?
I wanted just to ask you, Dr. Pagano, it seems like the internal mammary artery is the magic ingredient here because incomplete revascularization in surgery, which is not often very incomplete. But when we do these 10-year follow-ups, you have to admit that the vein grafts, many of them are gone by 10 years. So in the modern era, with the recent information about radial artery, looks like that's pretty good. Is there a change in the surgical technique?
So I can say that of all the data on arterial grafting, if you look at randomized data on arterial grafting, the radial artery is much more promising. And I think the positive thing about the radial artery, it could be technically easier to use than a double mammary. It has less complications. Of course, it's not available for everybody. And we need to be pushing more for the use of the radial artery. And we need to do that in a number of ways. Education, and that's the role of the associations as well, proper training, but we need to make it a quality marker. If you make it a quality marker and you measure it and you compare, or with the basis of the education, I think it's more likely to occur. So I agree that we should be using more the arterial artery, the radial artery, particularly in the younger population.
Dr. King, if I can make a small advertisement, just look forward for JAMA in 2 weeks and you will have also another very important answer to your very relevant question. We are working on it.
Excellent, excellent. Well, look forward to that.
Okay, I think this may conclude the session. I'd like to thank my co-moderator, Dr. King, all the panelists, and the two outstanding presenters. I hope that we have provided some food for thoughts for our audience. And the most important message I want to take out of this is that we all value the importance of discussing patients in a heart team. Thank you.
Thank you.
Thank you very much.
Thank you all.
Thank you. Thank you. Thank you all.